on transoral laser microsurgery. I just want to make sure I'm unmuted for laryngeal cancers. And it's really changed the landscape with regards to laryngeal cancer, especially glottic surgeries, from invasive to much less invasive. But of course, it also changed a whole cancer dictum, where it was previously thought and taught that a cancer should be taken out as a whole with large and clear margins. And laser microsurgery came and flipped it on its head, where it basically said you don't need massive margins, and you don't need to reset a cancer as a whole. And I'll come to the bread slicing technique later on. And then as a subtitle, you can see there, it says in parenthesis, it says oncologically radical, but less surgically radical. And that's the words of, if I remember correctly, Wolfgang Steiner with regards to transoral laser microsurgery. So this morning, I'm just going to be providing a background, and then I'll go on to anatomical considerations. I'll dive much deeper into the ELS classification, which, along with Prof. Steiner's seminal work, also came and standardized transoral laser microsurgery. And then lastly, I'll look at recent literature publications. So just as some background, laryngeal cancer contributed to 13,000 odd new cases and 3,700 deaths in the US in 2018, and to 150 odd thousand new cases worldwide in 2012, according to the National Cancer Institute's Cancer Stat Facts. And it's really significant in that it's contributing to 30 to 50% of all head and neck cancers in most regions, especially developing countries where smoking is still very prevalent. So going on, it contributes, adds to 0.8% of all new cancer cases, 0.6% of all cancer deaths. And despite a decreased incidence in developed countries due to a decrease in smoking, the 5-year survival of 61% odd has changed little. However, that's taking into account the whole spectrum of stage 1 to stage 4 laryngeal cancers. So the current surgical modalities, the first important thing to mention is that current treatment paradigms has 3 main areas of importance. It focuses on cure first of all, on secondly preserving the larynx, and thirdly on outcomes offering the best quality of life. As far as I know, in the 90s, they tried to flip it around, where the focus was on T3 cancers, more on preserving the larynx, which, as I mentioned in the previous slide, affected the unchanged outcome. So I just want to emphasize that the first importance is a focus on cure, local control, and overall survival. With regards to T1 and T2 cancers. The treatment options there mainly include transoral laser microsurgery and open partial laryngectomy with regards to surgery. I might add that primary radiation is, of course, also a treatment option. And with regards to T3 and T4, the treatment options are total laryngectomy, which I didn't add, is adjuvant chemo radiation. And specifically for just T3, mostly is chemoradiation. So going on to our main focus this morning is T1 and T2 glottic cancers. They overall have a reliably excellent cure rate. You'll see later on with T1, it's in excess of 95% local control and overall survival. And that is mostly irrespective of treatment modalities. Like I said, local control and laryngectomy-free survival exceeds 90%. And this is following primary radiation or surgical resection. And then important then is this whole transition in the 1990s from open partial laryngectomy to transoral laser microsurgery. And the two main drivers of this change was Prof. Wolfgang Steiner's seminal work in 1993 and the ELS classification scheme, which came to standardize this major radical work from Prof. Steiner. So going on to there's this study done previously on focal fold cancer transoral laser microsurgery following the ELS laser cordectomy classification. And this publication just went and looked at which of Prof. Steiner and the ELS classification brought about the biggest change with regards to publications which followed these. And this publication, this analysis of publication shows a massive increased growth during the time period following the ELS classification over time period as compared to Prof. Steiner's study. And this just shows that the ELS came to standardize this whole treatment paradigm shift. So just on with regards to Steiner's publication, this study quoted that it's a technique so aggressively bucking the accepted oncological dogma that it's resulting aftershocks were felt for years following. And with regards to the ELS, they quoted that we believe that a non-standardized surgery, which requires years of training to understand its limits, offers little reproducibility to the majority of laryngologists. And the goal of the ELS was to create a technique and treatment option which offers wide application, also with regards to studying or publishing results. So next up, we just are going through a few anatomical considerations. The larynx is might I add, a piece of art. It consists of 3 paired and 3 unpaired main cartilage structures. And I'm just quickly going through these. Of note is the quadrangular membrane, of which the lower free edge forms the false vocal cords, and the conus elasticus, of which the upper free edges forms the true cords. And I'll just mention something on Brohl's ligament later on. And then focus, just going on to subregions. As we all know, the larynx consists of a supraglottic region, which has the laryngeal inlet, the laryngeal ventricle area, which is or consists of mainly the glottis, and then the subglottic region, which is starts from 1 centimeter inferior to the true cords or the ventricle. Very important, the blood supply is mainly from the superior laryngeal artery coming off the superior thyroid artery. There's not really blood supply from the inferior thyroid artery going to the laryngeal cartilage framework, as you can see here. And the main nerve supply is via the external and internal branches of the superior laryngeal nerve. Important to remember is that the external branch of the superior laryngeal nerve is supplies the cricothyroid muscle, and all the rest of the intrinsic laryngeal muscles are supplied by the recurrent laryngeal nerve. And important also to mention the histology or the layers of the true cord consists of an outer mucosal layer and then a superficial, intermediate, and deep layers of the lamina propria. And then the deepest layers consist of the thyroarytenoid and buccalis muscles. And this is very important when considering the classification scheme of the ELS with regards to transoral laser microsurgery, of which I just want to mention also important for exams are the outer layer of the supraglottis and the subglottis consists of pseudostratified ciliated epithelium, and only on the true cords there is a non-keratinizing squamous epithelium. Voice production consists of the opening phase and the closing phase. Opening phase with increasing subglottic pressure, and then opening phase increasing subglottic pressure, and then the closing phase consists of elastic recoil with the Bernoulli effect. Quickly on clinical presentations, supraglottic tumors mainly present with neck masses and local symptoms such as dysphagia, muffled voice, and airway compromise. Glottic tumors present with hoarseness, stridor, chronic cough, and hemoptysis, as well as referred otalgia. However, referred otalgia can be present in all these subdivisions of laryngeal tumors, and subglottic tumors mainly present with stridor and dyspnea. Then we're coming to lasers in ENT. It stands for light amplification by the stimulated emission of radiation. Einstein first postulated the theoretical foundation in 1970. Maimon built the first laser in 1960, and shortly after ENT started using the laser. And two important advances for these were the development of the CO2 laser in 1965 already. However, taking into account during this period, they landed men on the moon, and then articulating arm in 1968. So with regards to the laser effects, absorbed laser light in the tissue, it's to 100 degrees Celsius initially. There's then an area of, next up is vaporization of intracellular water with resulting vacuoles, craters, and tissue shrinkage. And then it continues to heat the tissue to several hundred degrees, which leads to carbonization, disintegration, smoke, and gas. At the center of the main contact area of the laser beam, there's tissue vaporization with carbon debris. Adjacent is the thermal necrosis, and on the next layers consists of an area of thermal conductivity and repair. Important with regards to laser effect, it seals the small vessels, nerves, and the lymphatics. And it is postulated that this contributes to prevention of spread or transfer of cancer cells to the adjacent tissue. And another benefit of laser, or postulated benefit, is that there's an absence of post-operative edema. And working in the airway, this is very important to take into consideration. This is just to give a visual image with regards to the effects of laser, area of vaporization, necrosis, thermal conductivity, and repair with the normal tissue layer deeper down. Strong and Yaku first used lasers in 1970, and as mentioned before, Wolfgang Steiner produced his seminal work in 1993 with excellent and reliable outcomes, showing that preservation of laryngeal function is possible by using a piecemeal resection. Theoretical basis of TLM is that it violates the time-honored dictum of surgical oncology, which dates back to the 1800s. And the theoretical reasons that laser surgery permits local cancer ablation is that cancer cells do not adhere to the beam of light. There's no physical carrier to transplant the tumor. Cells are revealed by laser surgery are thermoregulated and destroyed. And another great benefit is that the wound is not closed, and that in an MDT setting, we can closely follow up these patients on mostly 3-monthly basis initially to inspect the larynx with flexible laryngoscopy. So very important to know for head and neck and general ENT practice is the classification. And this classification was published in 2000, titled Endoscopic Chordectomy, a proposal for classification by the Working Committee of the European Laryngological Society. Immediately going to dive in. Type 1 is a subepithelial chordectomy, consists of resection of a vocal cord epithelium, passing through the superficial layer of lamina propria. It spares the deeper layers of the vocal ligament, and these are mostly used in cases of vocal cord lesions suspected of pre-malignant or malignant transformation. And the roles are twofold, mainly diagnostic or for histology, and it can also be therapeutic to use in lesions with histology confirms no microinvasion. Type 2 is a subligamental chordectomy, consists of resection of the epithelium, Reinke's space, and the vocal ligament. The vocalis muscle, the deeper layers are preserved. It may extend from the vocal process posteriorly to the anterior commissure anteriorly. And it also consists of both diagnostic and a therapeutic indication. Diagnostic indication is for severe leukoplakia with suspicion of neoplastic transformation. And the therapeutic indication is for microinvasive cancer, just involving the superficial layers, or for severe carcinoma in situ with a possible microinvasion. And then transmuscular chordectomy, the one we use most often for T1A mid-chord lesions, is where the vocalis muscle is involved in the resection. And for exposure, a partial resection of the ventricular fold may also be necessary. And this is also very important for subsequent follow-up of the patient. And the indications of a type 3 is for small superficial cancers of a mobile vocal cord and cancers reaching the vocalis muscle without deeply infiltrating it. And those two just describe a T1A, mostly mid-chord lesion. And then a total complete chordectomy, a type 4, extends from the vocal process to the anterior commissure. The depth of surgical margins includes the internal perichondrium of the thyroid ala. And important is that with the type 4, the attachment of the vocal ligament to the thyroid cartilage is cut. And the indications are purely curative, not diagnostic. And these are also for T1A glottic squamous cell carcinomas. And important that these need to be diagnosed before surgery. It's important to have histology available, as in a TB prevalent society, we first need to exclude a laryngeal TB before embarking on this surgery, or of course papillomas as well. Extended chordectomy is a type 5, and it's subdivided into 4 groups. 5A, which includes a resection of the contralateral vocal cord. Type 5B, which includes arytenoidectomy. Type 5C, which includes resection of a ventricular or excision, microsurgery of the ventricular fold. And type 5D, which includes excision of a subglottis to a depth of 1 centimeter. Type 5A is a resection, includes the anterior commissure and entire contralateral, and a segment or the entire contralateral vocal cord. And the resection continues along the cartilage at the height of anterior commissure, thereby removing the Brill's ligament. And if necessary, it can be extended to the subglottis. And these are mainly for T1B tumors involving the anterior commissure and extending to the contralateral cord. Type 5B includes resection of a partial total resection of cartilage and the posterior arytenoid mucosa, which is then preserved. And the indication is for vocal cord carcinoma involving the vocal process posteriorly, but sparing the arytenoid. Type 5C is an extension of chordectomy to the ventricular fold, and this is done for cancers involving the ventricle and cancers that spread from the vocal cords to the ventricles. And then 5D encompasses the subglottis to expose the cricoid cartilage, suitable for T2s. However, this is a contraindication according to some surgeons. And in 2007, the classification was revised to add a type 6, and this includes only an anterior commissurectomy. These are done for a lesion from the anterior, involving the anterior commissure without infiltrating the thyroid cartilage, according to the classification. So just to sum a few words on technique. There's an excellent chapter on the Viljoen website, which you can read, which goes into detail. I'll just touch on the surface. So the technique includes serial sectioning, also known as bread slicing the tumor. So one can determine the depth of the tumor and where normal tissue starts. This is used for all tumors other than very superficial ones, as I've said, to determine the tumor depth and to resect the tumor on the deep margin of the tumor. And the goals are then twofold: to ensure adequate margin, but to ensure that not too much normal tissue is resected, and to minimize impairment of the voice quality. These are just some very nice images showing the bread slicing technique. So one would start with A, bread slicing down the tumor to determine the depth, and then from B, resect superiorly to remove the inferior section, and then one can continue bread slicing again, resect on the deep margin, and resect the last part. And then very important is that these are mounted on a flat corkscrew, or some people even use a dried out cucumber. So the pathologist knows exactly where the deep margin and free edge is in order to give accurate margins. However, of note is that a surgeon's feel for margins are very important, and even though pathologists sometimes note that there may be involved margins, it's very important that a surgeon intra-op notes if they feel that they've got completely clear margins with microsurgery, and where follow-up can be done instead of immediately jumping to re-excision or adjuvant radiotherapy. And then a few considerations. The main contraindication to the surgery is poor visualization. Taking into account limited mouth opening, narrow mandibular arch, limited oropharyngeal inlet, and relative macroglossia. And it's important that especially junior or inexperienced surgeons know when to bail out and when to get experienced help or refer appropriately. Other contraindications, as with almost all surgeries, are severe cardiopulmonary disease, which will make anesthesia quite difficult, and anticoagulation, despite the published reports of post-TLN bleeds, are a relative contraindication. Complications are generally uncommon. I'll come to a study later on which goes into a bit more details with regards to published complications. And there's 1% incidence of multicysts during the 2 first weeks post-op, and all the individuals with age-related decreased in sensation of the pharynx may have initial difficulties with swallowing, and it's important to get speech therapy involved early for these cases. I might also add that those are more often seen with transoral laser microsurgery for supraglottic lesions, but it can also occur in glottic surgery. A quick word, I think its use for supraglottic squamous cell carcinoma is a whole nother presentation. But again, it can be used for these. Its indications are, of course, like with all of these, adequate exposure. For T1 and T2 tumors, it can be cancers of the epiglottis or the ventricular folds without infiltration of the pre-epiglottic space. And I might add that one would need to do a neck dissection for early stage supraglottic cancers due to its high propensity for N0 spread. And then for T3 tumors, it can be done for spread to pre-epiglottic adipose tissue with mobile vocal cords. But these are more done in institutions where there's a protocol for T3 tumors to be done with, initially done with transoral laser microsurgery. And then I'll just go over some literature. An important study is with regards to transoral laser microsurgery versus radiotherapy for T1 glottic carcinoma. This was a systematic review and meta-analysis, and it showed that laser resection was significantly better at laryngeal preservation with a significant p-value, and there was no differences with regards to local control on this systematic review. It was also done by different authors for T2 glottic squamous cell carcinoma. And yeah, it's also similar, is that weighted averages for local control at 5 years demonstrated similar results, 75.8% for radiotherapy versus 77% for transoral laser surgery. I might also add here that the benefit of transoral laser microsurgery is that it can be repeated multiple times, whereas radiotherapy immediately limits one's options for further treatment, whereas it can't be repeated, and that these patients will often require a salvage laryngectomy. And then a very important study is the cost effectiveness of transoral laser microsurgery versus radiation. And one can make an argument, especially in resource-constrained settings, is that a laser will pay off itself over a whole period of use, where that's probably not possible with robotic surgery. So this study showed that radiation therapy as the initial treatment strategy was found to be definitely more expensive, £2,600 versus £600, and less effective than transoral laser microsurgery. This was, I'm sure the study also took into account that patients had to come in for multiple radiation treatment days during the treatment period, whereas transoral laser microsurgery is a day procedure and the patients can go home the next day. And the conclusions were for the study is that transoral laser microsurgery is a cost-effective strategy to adopt in the management of T1A laryngeal cancers. However, there are some uncertainty with regards to the optimal strategy to adopt in T1B and T2 laryngeal cancers, but definitely a benefit in T1A. And then the study was done in 2016 with regards to reasonable limits for transoral laser microsurgery. And controversial applications include inadequate laryngeal exposure, anterior commissure involvement in the craniocaudal plane, invasion of the posterior paraglottic space with a retinoid fixation, which makes it a T3, massive infiltration of the preepiglottic space. Also, these are T3 laryngeal tumors and minor thyroid cartilage erosion. So the main controversy is to which extent can TRM be used in T3 cancers. But in our setting, it's definitely not applicable. Might be, but not really. And the summary of the study is that satisfactory oncological results are achieved with TRM when applied to T1 and T2 tumors, and only in centers with a protocol in place with accurately selected T3 glottic and supraglottic cancers with favorable exposure. The study I alluded to earlier just mentioned some complications. Intraoperative complications include lost tooth, and very important is to take into account the risk of airway ignition. Just a word on that, if there's an airway fire, it's important to make sure that, especially in a patient which is intubated, to immediately immediately talking to the anesthetist, remove the endotracheal tube, because the endotracheal tube is serves as a source of fueling the fire. That's the word. It's a fuel. So immediate post-op complications include episodes of post-surgical bleeding and dyspnea due to airway edema. And delayed complications include aspiration pneumonia, neck abscesses, stenosis of the laryngeal vestibule, and thyroid cartilage chondritis. Then a study done in 2017 by Kate Stevenson and Prof. Fagan with regards to transoral laser resection of glottic carcinoma. What is the significance of anterior commissure involvement? And this study showed that it consisted of a group where patients had clear margins and involved margins. 30 patients had involvement of the anterior commissure out of around 63 patients. And these patients were significantly more likely to have uncertain or positive margins, and were also more likely to receive adjuvant radiotherapy. However, the overall laryngeal preservation rate was still 96%, and there was no statistically significant difference between those with or without anterior commissure involvement. So the study concluded that transoral laser resection with the use of adjuvant radiotherapy in a minority of patients with adverse pathological findings can definitely be recommended for the primary treatment of anterior commissure glottic cancer from an oncological perspective. And then going on to a word just with regards to Broyles ligament. Historically, there was a big concern that anterior commissure lesions invaded through the Broyles ligament into the thyroid cartilage, turning what could be a T1B clotting tumor into a T3. However, studies done, or according to the literature, vocal folds attached to the thyroid cartilage by the Broad's ligament, and it's a union of the thyroepiglottic ligament and attachment of the vocal ligament, and it consists of dense fibroelastic tissue without glandular structures. So some authors consider this a weak point where tumor can penetrate the cartilage, transforming a T3 into a T1 into a T3 or a T4. T3, as you know, inner thyroid cartilage, T4, outer cortex of the thyroid cartilage. However, some authors consider that this ligament protects the cartilage, and tumors with superficial extension, especially in the horizontal plane, rarely show thyroid cartilage infiltration. This study by Jumaili and his colleagues was on the prognostic significance of also surgical margins of the transoral laser microsurgery for early stage clotting squamous cell carcinoma. And in this cohort of patients, 13.4% of patients with a negative margin received radiation, and 47% with a positive margin had adjuvant radiation. However, taking into account these, the 5-year overall survival for those with a negative margin status was 82%, and those with a positive margin status was 80%. This was not statistically significant. And their conclusion was that positive margin status did not negatively impact on overall survival, as one can see there. And then I'm just going to end off with showing this article. It's a great article written by our dear friend and colleague in Spain, Carlos Chiesa, and it's excellent to read, especially for exam preparation. It's with regards to CO2 transoral laser microsurgery, benign premalignant and malignant lesions of the glottis, and this is a very thorough literature review. So I'm going to end off, as I see most people are luckily not sleeping yet, is that according to Steiner's works, it's oncological radical, but surgically less radical. It presents a massive paradigm shift, which was driven by his seminal work and by the ELS cordectomy classification, which provided a technique and treatment option which offered wide application. And it provides, or it leads to few complications in the right hands, with great and satisfactory oncological results when correctly applied. And that's it for me. I'm just going to stop share, and then I will unmute everyone, or allow unmute, and I will open the floor to, first of all, Prof. Fagan, and then for a few questions.
Okay, just an overview. Perhaps you want to ask Kenneth, how do you coming from Ghana, because they've got a CO2 medicine machine. Kenneth, you want to comment?
Kenneth, can you hear us? Would you like to comment? I think there we go. That should be better. Apologies for that.
Perhaps just like a comment in the meantime. Kenneth, when you were discussing the ELS classification, you referred only to T1 carcinomas. but you didn't refer to the T2s being included, or T2s being addressed in the classification.
So I think that T2s are mainly addressed with regards to the type 5 resection, involving when doing type 5D resection of the ventricular fold, if I'm not mistaken. So it definitely comes into play, and the T2 can also involve fixed vocal cords, so not fixed, partially mobile vocal cords, reduced mobility. So that's it. I think it can definitely be done for T2s. However, I think it needs to be, like I said, good exposure and all the rest.
Some T2s with reduced mobility that are suitable for resection with the type 3 resection.
Yes.
So I'm surprised that, but I think one of the difficulties with assessing people's results is how radical they are with surgery. So it's hard to control for that. I mean, some T1As I would take type 1 resection, and I would go straight for type 2, type 3. So I think that's one of the difficulties. Kenneth, are you there? You want to comment?
Kenneth, can you unmute? Let's see. Perhaps we can ask, I see Prof. Hiller, you have a raised hand.
Yes, good morning, everybody. Hello, how are you?
Well, thanks, Prof.
Greetings, everybody. I must just say that I can barely hear what Johan Fagan was saying, and there's a bit of an echo.
I was just saying that that when Gerrit was discussing the ELDS classification, he didn't really refer to the T2 tumors being resected by transoral laser surgery, but certainly I think obviously there are T2s and T2s, but many of those that are classified T2 due to reduced vocal cord mobility are very suitable to resection.
Yeah. What I would like to raise, I don't know, probably it's too little time to discuss it here, is the whole issue about histological verification, because I've got 3 points to raise. Number one is that because you're transecting tumor, obviously the orientation of the specimens that you submit is of vital importance, because there are many steps in the histological processing that can lead to the wrong interpretation of your resection specimen, especially for histological verification of your margins. So that's one point. The other point is that what is the relevance of a margin in superficial resections of let's say T1 and T2 vocal cord tumors, because I understand you can go back quite easily if there's recurrences. And what is considered a close margin, what is considered a satisfactory margin?
The margins, certainly if it's a mid-cord T1A, it's a vocal fold lesion and are resected, and even if it's if it tumors at the margin, if it's a patient who's reliable in terms of follow-up, and they want to preserve their voice quality, I might just watch them. But if it's a tumor which is at the anterocommissure or posteriorly, and the margin is positive, then I would either go back or I would radiate it, because then recurrence might be catastrophic. So I think it depends where the tumor is, and what you think is going to happen if a tumor does recur, how you can salvage the situation.
Okay, so because the carbonization margin of this procedure, what is that, about a millimeter? Because of it's different from cold steel. Do you anything know about it, Gerrit?
Prof. Viljoen, I'm not sure about that.
I think it also depends on how you use a laser. If you have good traction on the tissues, then there's far less carbonization. Whereas if you don't, you're going to have far more carbonization. So I think it also depends on your surgical technique.
Yeah. You see, for the pathologist, we're dealing with several issues. Number one is that often the orientation of the submitted tissue is not handled by a pathologist. It's handled by a technician. And as it goes, usually, and because there's a lot of small specimen processing that does not go to the hands of pathologists because the tissue is rather embedded. And the problem is that technicians don't have a clue what transoral microsurgery is. And also they don't know how the specimens are resected. And so I think it's very important to make sure that a pathologist does cut up or does basically process your resected. That's number one. Number two, in such a way that the pathologist understands what he or she is looking at. So I know that there is the use of ink and pencils. There's a special pencil that I once was given by Peter Ambrosch, which is a formalin resistant, but water soluble pencil that you can use to paint your margins as soon as you've resected them. And the other thing is that obviously you can pin your specimens onto a piece of cork or paper and then clearly indicate what is buccal, what is obviously lateral, central, deep, and so on. So, it's a whole procedure. And the thing is that I just wonder, I think most pathologists, when they look at these specimens, they don't really know what they're looking at. They see carbonized tissue, they see tumor, pieces of tumor, that are infiltrating the tissue, but you can't assess the depth because depending on the orientation, the way it's cut. And also, I don't know whether the results actually all that reliable, especially when the margins are very small or non-existent. These are all issues that I don't have any answers to, and I don't also know how really relevant it is, because I believe that it's actually the surgeon that looks visually at the resection of the tumor rather than depending on the histological report, unless you've got massive tumor at the margin. But you already know when you resect it because you can see it clinically.
Thank you.
Kenneth, your hand is up.
Yes, thank you very much for a very nice review. Our experience has been very limited, basically due to the fact that we don't get too often very early disease. But then of the few we got, the T1As, we treated them with laser, and we have good results to date. I did one with a T2, and he was coming from DRC, but because of COVID, he couldn't come for review, and at the time he came back, he had recurred, so we treated with radiotherapy. Otherwise, it has served us well. The only drawback now is the machine has a few challenges which we have to send for repairs, and we are waiting for the technician to come sort us out. Otherwise, we are fine here. Thank you.
Thanks, Kenneth, for those comments. It's always a machine dependent, and that's also the issue. If a laser machine can break, how more severe can a robotic surgery or robotic machine be able to break, and the maintenance on these. But those are maybe comments for another day. I don't see any other questions or comments, but thanks everyone for joining. We'll see you on Friday.